Hello everyone, and welcome. The webinar will start in 5 minutes. Thank you everyone who joined us so far. Let's wait for a few more minutes for more participants to join, and we will start soon. Okay, good morning, good afternoon, and good evening. Welcome to the International Fertility Group's online workshop on stem cell therapies for enhancing ovarian function in IVF practice. My name is Sophia, and I will be your moderator for this session. Our three main objectives for this session are to discuss the following: the latest evidence on stem cell therapies' impact on oocyte quality and ovarian function in IVF cycles, strategies for incorporating stem cell therapies into your practice to potentially improve success rates, case studies, and practical considerations for patient selection and treatment protocols. I'm confident that this will be an engaging session, but not without your participation. Please feel free to ask questions via the chat box, and they will be answered after the presentation, which will last 30 to 40 minutes. We will also have a special announcement at the end, which will benefit all of you who are interested in advancing your practice in stem cell therapies. So stay tuned till the end. Now, let me introduce you to our speaker, Dr. Ulyana Dorofeyeva, a leading IVF expert with a PhD in PRP Ovarian Rejuvenation in IVF cycles. Her global experience, matched with her advanced techniques, is the reason why we are fortunate to have her share her expertise with us today. And without further ado, I'll be giving the floor to Dr. Ulyana.
Thank you so much, Sophia, for the kind introduction, and great thanks to everyone who joined our today's webinar. This is the first meeting within the series which we decided to perform during the summertime, because in the end of the summer, for September, we are planning the workshop in one of our clinical facilities with the practical experience on which will involve the ovarian rejuvenation using the stem cells for the patients who require this treatment. So we will tell more about this opportunity later. However, this is really important stage of our development in terms of the clinical practice. You know that IFG is a leading provider of the services, and we are helping our patients to meet with the technologies, the innovations, and we are helping them to reach to the goal, which is healthy baby delivery. Our main product for current practices is the mitochondrial donation, spindle, and the pronuclear transfer. However, this is a middle point of creation of the embryos. In order to be successful in the embryo creation, we need to have eggs. And the challenges we are facing for the patients of advanced maternal age and those who are reaching out to us in order to be helped, they are those where, from the medical point of view, for me as an IVF doctor, I feel responsible to do my best in order to help them to create as many oocytes as possible within the short period of time, because they are eager to move forward using the technologies and getting into the stage of receiving the blastocyst, receiving a healthy blastocyst, having an embryo transfer, carrying the pregnancy, and deliver their baby. So that's why this is so important to use the technologies. I will be totally open with you that we started to use the stem cell therapies just recently in January 2024. Before that, we have been using PRP, as this is the practice which has a lot of discussions around, and different practitioners will tell you, based on their experience, on the experience they had with their patients, was it successful or not. However, my answer for this is that we need to define a patient. We need to select the proper patient for whom the specific technology will be helpful. And this what we are not deep in this webinar because this is the first and introductory webinar about this technology, but we will have another series to go through the details together with the producers of the stem cells and the algorithm, how we exactly are using the technology and sharing our data. However, let's start. So, as we all know, our biological clock is always running, and even during this next hour, women will lose some of their potential, because this is a constant process within the time frame that we are producing a specific number of the follicles and we are losing them within the time. In contrary, men will produce more sperm samples, which is that's why we are talking mostly about female infertility and how the stem cells may help. However, as the issues may be really global and they can depend on either men or women. However, this percentage of men is really, really smaller compared to the population of women to whom we need to help. So into one of our webinar, we requested urologist to join and to share his experience in order how to help men with the stem cell treatment. However, now we are talking about the ovaries, the follicular genesis, about oocytes, and further details about female infertility and the potential. So the ovary is the female gonad, which serves as a source of the germ stem cells and the germ cells, and is a major supplier of the steroid sex hormones. Why we need to start from the ovary? Because that will be our target organ. We are talking about stem cells which we are going and which we are injecting into the ovary. We are not talking about the systemic use of the exosomes or the stem cells, even though it is one of the practices which are held in some different clinics or the institutions. So our practical experience goes for the intra-ovarian rejuvenation of the tissue using all three technologies which are currently available, and we will talk about the difference of those, which is PRP, exosomes, and the stem cells. We know about the human germ cell number and the potential to produce the follicles and the oocytes. So baby girl is born with over 7 million of the germ cells, which are potential to differentiate into the oocyte. After the first mitosis, once we are born, we are reducing this number to, in average, 2 million of those cells. And once we are getting into the puberty, the girl who starts her menstruation, she has around 500 cells which are available. Within the period of the fertility, while it's usually between 11 and now it goes even younger, up to 50, 45, the time is different, and we will talk about different cases for when we are in the period of the perimenopause or the menopausal period and what is happening there. We are having, the scientists, we are calculating about 400 to 500 cycles of the ovulation, meaning if in each cycle we ovulate just one follicle where we are performing or where we are growing the oocyte, so those are just 400 to 500 oocytes which we are using within our lifetime. However, we are having multiple numbers, those several millions which we are having on the start, and in each follicular cycle, menstrual cycle, we are growing specific cohort, which for the young age is about 20 in average. For advanced maternal age, it's still around few, let's say 1 to 10, or if we are over 45, this is 1 or 2 in each cycle, but still they are there. The question is how we are using them. We are talking a lot about preserving fertility, and this is very effective option, which definitely gives hope and the opportunities for the further treatment for patients in their advanced maternal age. From another side, we are having a lot of techniques and the technologies to preserve our beauty and to work on the cells and tissues which we used to take care of. Why we are not taking care about our ovaries if we are focusing on this so important organ and the functionality of this organ for such an important goal as the delivering a baby. So if you're talking about follicular genesis, first we need to understand that this is also a constant process which takes around 200 days from the very beginning, from the very early cells in the development, which will then differentiate within the factors which will activate their differentiations into the primordial follicles, which is the cohort of the follicle where endocrine factor, metabolic factors, many of the biochemical factors will impact their development and the differentiations further, and then they will start to be gonadotropin dependent. So they will be sensitive to the additional dosage of the gonadotropins, which are the main moleculars of our fertility drugs. However, there is a very long process, which we used to say it is around 120 days for the activation, before differentiation and the activation for those primordial follicles with the germ cells. And then there is another period of time, which is around 80 days for the selection from the very early primordial follicle to the primary follicle to the secondary follicle, which will then become the pre-antral, which will grow the oocyte inside of this follicle, and then the antral follicle, which will be able to produce the oocyte further and to ovulate. So we need to remember, because we will go back to this timing quite often in this webinar, that we are talking about follicular genesis, which is around 200 days, meaning what we are recruiting in this particular cycle, where we are starting the stimulation for the specific patient, meaning that something which continuation of the process which started several months ago, closer to half a year ago. So many factors are impacting. And what we are losing as the potential of our follicles, this is 99.9% of the follicles are lost within our lifetime. That's why this is also important to focus. So here we are just going more into the details about how small the follicles are and the cells which we are planning or which are activated within all the scheme and the paracrine and the endocrine and the different environment and all these micromolecular changes which are happening inside of the tissue. And the question is, are they there? So we are talking about which technology will be helping us to create new follicles. Is it possible in order to create the new follicles, or the technologies are still helping just to force the development of those follicles which are currently there in our ovaries? And how many do we have of them? And can we speed up their process of the development? And can we somehow impact the fact that this follicle will be an adequate follicle in terms of the development, and we should really expect this follicle to produce an oocyte? Because another issue is that how many follicles we are growing within the stimulation cycle. Unfortunately, some of those follicles are empty, or we were not able to develop an oocyte in this follicle. And this is very sensitive also issue for our patients in advanced maternal age, which are counting each and every follicle whenever the time they started their treatment, and they are following and they supervise the monitoring, like the hormones and the ultrasound scans and the measurements on these scans and so on. Also true that the average age for the first delivery in the world is increasing, and we always deal, like for me, for my practical experience since 2008, I always dealt with the patients of advanced maternal age. Those were patients back in 15 years ago who were looking for the opportunities of the oocyte donation treatment because they were sad that unfortunately this is the only option, and that was the most effective and the option which shortage the timing between once they start their treatment until they get the pregnancy. So we had no other solution for those patients back in 2008. Then we developed the technology which was an alternative for the oocyte donation, which I'm happy to share about it as well today, which is the mitochondrial donation. Or still the patients were changing the protocol and they were trying to have their own IVF treatment, but the chances, if they are in their advanced maternal age, of course, are very low. So the truth is that per every decade, every 10 years, the statistics shows that the age of the woman who delivering the first baby is increasing by 2 years. If we will keep to that tendency, and we believe that that will be the case, very soon in 2100, the women will have wish to deliver babies in 51, and generally society lives longer, and we need a solution for those patients right now. and especially we will need it for the future. That's why IVF is developing so rapidly. And if we were not talking about clinical use of the stem cells even 5 years ago, now we are having this as a clinical indications. We have a lot of animal studies. We are using the stem cells into the different organs and the systems of our body. So let's understand how we may use this effectively for the fertility as well. Of course, while we understand the levels of the evidence, we will not find any systemic reviews or the randomized controlled trials. And this comes just from the fact that technology is really new. So most what we will get here, we will get the animal models, and we will get the safety of the protocols coming from there. And then we will have the clinical cases based on which we will understand how that works. But we need to understand as well that every patient will be different. Specifically, if we are talking about this population of the patients which are advanced maternal age or those which have premature ovarian failure, because that can be a patient of 28 years old, but she will have her IMH less than 0.1 and she will need a solution. Or that will be a patient of 48 years old, which is 20 years different, and she will also have her IMH will be 0.15 or even higher, and we had such cases. So should we say no to one of those patients, like we cannot help you, or you should just switch into the standard oocyte donation program, which may be the case, and this is always a decision of the patient. What really should be her direction into the fertility journey? Because both technologies may work and they do work. The question is, what is her time, efforts, unfortunately money, which she wishes to spend into this technology? But also the safety is number one, because the main goal is to help patients, not to create any problems, of course. So every patient for advanced maternal age and who are considering this technology is individual. And we cannot say that we are having a protocol, one protocol for all. We do not. We are considering different clinical indications, all the anamnesis, and many specific factors for this specific patient in order to create her individual protocol. That's why we always support individual treatment at International Fertility Group, and this is very, very important practice. If we are talking about predictive factors, so one of the predictive factors, however, this is not the main one. This is just one which we will definitely ask for. That would be the anti-Muller hormone, and we have you will ask, have we seen the cases of that the IMH will increase? Yes. Do we always consider to check the IMH between the treatment cycles? No, because the main factor or the main goal which we are focusing on, this is the number of the retrieved oocytes from the patient. Yes, we are focusing on the number of the follicles, but this is one factor. And the most important is the number of the retrieved follicles and the quality of the oocytes which we are getting as the retrieved oocytes. So we know the how IMH declines and how predictively the IMH will decline with like months or any period of time. And very often patients are asking, when should we start the treatment? And unfortunately, in some parties in the world, this is very relevant question, because the clinic will tell that we have a waiting period of time which you can have the visit to your doctor in 1 month, 2 months, 6 months, whatever. So we can start your treatment after a special preparation, or then you need to do X list of the screenings and the protocols and so on. So we are saying to our patients that we need to start immediately, and timing is so important. We started this webinar with the question about time, and still we will continue with this. So what we are focusing on treating our patients, this is focused on the primordial follicles. These are the the follicles which needs an activation or which will go through the process of the activation and then the further development. So in order to reduce the numbers of those follicles which we will potentially lose, to decrease this amount and to save every follicle from the process which we call programmed death. Because if we haven't used the follicle, if we didn't give the potential for this follicle to awake the oocyte or to create the oocyte inside, even though every follicle which is on the antral stage of the development, this follicle has a potential to grow and to develop the oocyte inside. There are the specific cells, which are TECA and the granulosa cells, which will grow with the response to the gonadotropin additional dosage of the medications. However, if we haven't started that stimulation, meaning we lost the follicle, and we will never have the potential to get it back into the ovary. So the offered techniques in order to save the pool of the follicles and to create the so important number of the retrieved oocytes, which we are using in our practice, is the PRP ovarian rejuvenation using the exosomes and the ovarian rejuvenation using the stem cells. Why, you will ask me, why still we are talking about PRP here? Because we named this webinar as the stem cell in IVF treatment, because we are having different cohort of the patients. And for the specific cohorts of the patients, and this is, we believe, not only because my PhD was about the PRP treatment and the ovarian rejuvenation, and that was, again, quite many years ago, so the practices has changed. But I remember very well that the conclusion was that for those patients who have preserved ovarian reserve, it's low, but it's still preserved, which was over 0.3 nanogram per milliliter, we were able to receive really reasonable number of the follicles if we were following the protocol and we were stimulating patient in the specific period of time when the PRP works the best for the best outcome. However, this is also true that for many cases we are doing back-to-back stimulations, like the cycles of the duostim or the stimulations in every cycle, just in order to reduce the timing when we are receiving the specific number of the oocytes and to increase the total number of the retrieved oocytes in order to proceed with the specific technology later on for the embryo creation and the further development. So just to remind you how the PRP is performed, we are collecting the patient autologous blood. We are preparing the platinum-rich plasma using the centrifugation. This takes us about 20 minutes to prepare the patient and to process the blood. And under ultrasound guidance, we inject the PRP across the ovaries. We are trying to inject it into the 4 to 8 areas around the within the ovary. Of course, like for some patients, we can do only 3. For some, we can do 8, and that is easy. That all depends on the volume of the ovary and the access to the ovary. So technologically, how to do it right or in the best way, we will be showing on the our workshop later in September. And we are checking the changes after the PRP, and also technologically, what is very important, once we are using the exosomes, the amount of the material which we are injecting into the ovary is really limited. So if we are talking about 1 milliliter into each ovary, so what we do in most of our cases, that we combine exosome rejuvenation with the PRP rejuvenation. Of course, the prevalent will be the exosome infusion. However, most of the ovaries and most of our patients, they do have the volume of the ovary where we can easily inject 2 milliliters. And if we are having just 1 milliliter of the exosome, then we are adding another milliliter of the platinum-rich plasma, and we see really great results as in terms of the outcome. And we believe that this works works in terms of combining the factors which are effective factors which work from the PRP injection, as mainly these are growth factor, together with the factors of the metabolic effect, which we are getting really great metabolic effect while we are using the exosomes. So while we combine both effects, also from the exosomes we are having the growth factors, but this just improves the quality of the technology, then we believe that this is the best what we can do for our patients. So let's talk about the exosomes, because the PRP, that's something what was discussed already, and it's quite controversial, but again, we need to understand specifically the cohort of the patients it will be effectively used for. But the exosomes, this is the newest treatment in terms of the improving the quality and the effectiveness of the stimulation of the in fertility. Exosomes are the extracellular vesicles that carry the proteins, nucleic acids, lipids, and the RNA, which are important in terms of the proper functioning and the development of the cohort of the follicles. They really play an important role for the follicular genesis because they mediate the cellular communication. We used to think on the beginning, once we were trying to understand these extracellular vesicles, and there was a lot of the discussion that the exosomes, this is something as a waste of the cell, but this is not true because there are different vesicles. Some of them, they are waste of the cell and they are apoptotic vesicles, but the exosomes are totally different. They are those helpers which communicate, which help to each cell to communicate one between the another one. So they are helpers. They are looking for the cell which needs a help, which needs a specific nucleates, or which needs an RNA, or which needs a specific protein, and they migrating between one cell to help another cell to grow or to develop, or whatever the cell is needed. They have very high biocompatibility, biodistribution, so they are easy to be distributed within the cell and the tissue where they were injected. They show really great results while we are using them systemically, but if we are talking about specific renovation and the rejuvenation or the regeneration of the tissue, and our focus is the ovary, so we believe that the right algorithm is to inject them specifically intra-ovarian. They have low toxicity and the low immunogenicity. Also, they are not cells themselves. So if we are talking about the risks, and we will be talking about the risks compared to the stem cells, which have unlimited potential to develop and they have much longer lifetime. Also, exosomes, they have shorter lifetime, which is from one side, this is the benefit because we can work with them specifically in the period we need them. But of course, compared to the stem cells, we need to understand that we will be the most effective in that specific period. So they target the cell internalization, ligand receptors interaction, and the lipid membrane fusion, which is also so important for the communication between the cells. They repair and regenerate the cells and help them to function well, and they also suppress the apoptosis. So the apoptosis, this is one of the process which we were discussing about the apoptotic death of the follicles. So of course, exosomes will not be able to preserve more follicles for the future. They will help them to grow, but they are really working well. And we started to see that within our data that we do not have that amount of the empty follicles for the patients who were injecting exosomes, or exosomes together with the PRP, compared to those patients who injected only PRP. Like, they are working for the quantity, but also because they are metabolic and they are helping to feed the cell and they are helping to bring into the cell what was really needed. They are helping this cell to develop better and to function better and to be the most effective. So there are different clinical trials and the animal models which were directed to the specific proteins and the factors which exosomes are forcing to grow and which are showing really great effects. So as this is introductory webinar, I'm not going to go deeper into these scientific details, but they are proven on the animal model of showing really great effects. What if we are talking about the stem cell? So this is the cell which is able to replicate itself and to replicate itself for the long and lasting period of time, and also the cell which is able to differentiate into many cell types. Of course, the stem cells, they are so different, and I was trying just to show the distribution into the different types of the stem cells based on their sources, because sources are also very important, not only from the ethical perspective, but also from the technological way of how easy they can be assessed and how easy is to get them in order to use them further. So there are embryonic stem cells which are delivered from the blastocyst inner cell mass, and you know that this is the most discussable, which we believe which is the most effective type of the stem cells, but they are those which are the most rare to be used so far. Then adult somatic stem cells, which needs to be reprogrammed, and they can be retrieved either from the bone marrow. Which is quite often we are working with this kind of the stem cells, or from the adipose tissue, and better for the generation of the stem cells would be the white fat. And this is something where we already have a practical experience of these cells to be used for our patients. So that will be the mesenchymal stem cells. And if we are talking about their classification in terms of the pluripotency, or the potential of being differentiated, so those which are embryonic stem cells, which are coming from the trophectoderm, we call them totipotent stem cells, and they can differentiate really into any of the stem cell type. But again, their usage is quite limiting right now. Then the pluripotent, they are also the embryonic stem cells. They can differentiate into the 3 generation of the tissues. Multipotent, the adult stem cells like the mesenchymal or the hemopoietic, they can differentiate into the limited range. So we need to, but now they are the most those which are used. So still they are covering the range where we need them to differentiate. If we are talking about ovarian rejuvenation, oligopotent, they are adult, which are myeloid or lymphoid, which will be just for the limited number of the stem cells, and the unipotent, so that's just a single cell type. If we are talking about differences between the platent-rich plasma, exosomes, and the stem cells, we need to start from the cellular composition. So we believe that the PRP and the exosomes, that they are those which will utilize the platelets and the growth factors, and they are own cells, and they have capacity of the self-renew and the differentiate, but they are not cells which are coming from the donor, because this is the biggest discussion which are currently not answered, or we need more trials in order to understand the difference. If we are talking about stem cells, should we prioritize using own stem cells and then reprogrammed stem cells, or we need to work with the stem cell banks, which is always also possible, and we have that practical experience, but we need to talk about immune response, we need to talk about the risks of the cancer effect, and also the risks of the unlimited growth of the cells, which we will not be focused into the growth. So this is the only issue which we are having right now about the discussion of the stem cells. if we are talking about regenerative potential, so definitely stem cells will have a greater regenerative potential compared to the PRP or the exosomes because they will work harder, they will work longer. However, if we are talking about understanding of the algorithm into use of the stem cells compared to the exosomes and the PRP, and I will show this further. So if we are talking about stem cell treatment, we are focusing on the activation. So we are on the very beginning of the processes of the follicular genesis because we are hoping to restore the ovarian function and to create the new follicles, which will be differentiated from the stem cells which we are injected into the ovary. Meaning, after they are differentiated, they need to develop, they need to go through the whole process of the follicular genesis, which is the timing of 200 days. So we need to follow the changes into our patient in order to wait to the best period of time as the effective treatment post stem cell treatment in order to see how the reserve really responds. And we have now quite limited number of those patients, but I will be presenting and I will be showing those cases where patients use the stem cells and how they responded lately after the stimulation. So the source we already discussed, and in terms of the safety and the regulation consideration, they have both, like all the techniques, and even we were discussing the PRP treatment complications and as well as the exosomes, but they are, if you will ask from the practical point of view, they are very rare. We never seen any complications, but while you are following the technology and while you are following the safety of the procedures, either this is the collection of the blood or processing of the blood or the injection of the treating solution into the ovaries. So if you do everything right, so we never seen the complications from these technologies. The only discussion, and we are having this discussion with the stem cell banks between like discussion about autologous or not autologous stem cells. So this is the only discussion we need to talk about. So while we are focusing about the individualized stimulation protocol for our patients, which are either in their advanced maternal age or they are patients who need a solution, we focus to rescue from atresia the every follicle. And if we are talking about full IVF cycle, because it's reasonable to proceed with the reasonable number of the oocytes retrieved for the whole procedure, and either we are talking about regular IVF cycle, which frankly speaking, we do quite rare, and we are focusing our potential into the mitochondrial donation treatment. And I am happy and I will be really happy if you will learn more about this innovative and really effective technology. But we would like to accumulate more oocytes from either one stimulation round, but of course that will not always be possible for every patient, and we are saying that we will be happy to have at least 4 to 6 or optimal to 8 oocyte accumulated from the different cycles from the patient, and then we will freeze them either as on the stage of the oocyte or the zygote, having 2 pronucleuses, and then we will continue with the full IVF cycle. So it's not like here that we are having one stimulation round and we proceed to the embryo development and to the transfer, but we are really quite long on the stage of the ovarian stimulation, egg retrieval, and the accumulation of the oocytes. So here you can see from our algorithm what we are discussing with our patient based on the fact how we categorize the specific patient in terms of her potential, of her reserve, what will be really helpful technology which patient should consider in order to improve her outcome from the ovarian stimulation, to reduce the number of the stimulations after that, and to increase the number of the retrieved oocytes and the quality of the retrieved oocytes. So for those patients which we have relatively preserved ovarian reserve, we are recommending exosomes and the PRP, and we believe that we are focusing on the process, on the end point of the activation and the beginning point of the follicular genesis itself, starting from the development of the follicle. So on those primary follicles, which are going to develop further. And this is true, and quite many groups have shown that even if you are talking about the patient who has really low ovarian reserve, and we call this sporadic follicular development, so still this patient could have follicle which will be growing in this month or the next month or 2 months after. So they still have some specific number of follicles. We will never know how many if we will not give a trial to this specific number of follicles to boost them and to develop within this short period of time. Of course, we need to supervise, we need to monitor the patient, and we are always saying to the patient that they need to prioritize their IVF treatment for this specific period of time, meaning they would need to do the hormonal monitoring, they would need to do the vaginal scans, we would need to see what's going on in their ovaries in order to understand and to address the specific follicular development and to help this follicle to be grown. It's not always helpful. Like, I need to say that and we believe that the exosomes and the PRP, like if we would grade the levels of which is the most effective or the most safe technique, or let's say soft technique. So the most soft technique will be the PRP itself. And then if that didn't work, we would go deeper into the combination of the PRP and the exosomes. And then we would understand that we are getting the best outcome from these injections and these interactions and the rejuvenation in about 50 to 60 days post the rejuvenation itself. And I will show you several, just exactly 2 today, but we have more cases which we really understood that if we are talking about PRP plus the exosomes, the best outcomes we are getting in the second month of the stimulation of the patient. And the level 3, which will be really something what we recommend patient to consider while just level 1 or level 2 didn't work, or their reserve is really low and we are just trying that's like a rescue technique. Very promising, but really the one where we have less information available and some questions in terms of safety, but we are addressing those questions. And I believe that every week we will have more answers as we are now cooperating with many clinics and the centers and the stem banks around. And I'm really involving you. I will be happy if someone who is watching this webinar will start communicating with us in order to join our actions in terms of understanding technology and giving better potential for our patients in terms of the effective treatment. But we are talking about stem cells on the period of just the beginning of the activation process, and we supervise the changes in the patients, but sometimes they are forcing, even though we injected the stem cells, and if we see just 1, 2 follicles developing, of course, we would recommend to the patient just to start the stimulation immediately. And just for a few of them, we already had that period where we reach around 200 days from the period when we injected their stem cells for the first time, and then we would understand more while the time would be further in order to understand how this impacts and what results we are getting. In terms of the stimulation protocol, I will not really stop a lot here. We are using different stimulation protocols for many of the patients. We decide based on their best outcome from their best protocol, and we know that for some patients really specific protocols will work better. A lot we are using dual stimulation just in terms to save the timing, and that's true that we are doing a lot of random starts. while we understand that we have the follicular waves, and it's not just true that we should start the stimulation in very early follicular stage, and while the follicle is either on day 12 or day 22 or day, while the cycle can be longer and either on day 30 there is no menstruation, but still we see the follicle which is secondary or early antral follicle, which will be sensitive to the gonadotropins. We will start stimulation exactly in this period of time. So here there is a data of our patients, which were patients for the mitochondrial donation, and the number of the oocytes retrieved per patient based on their age. But this slide, you see the outcome up to end of last year, to December 2024, sorry, while before we started to use exosomes, and here we were using PRP, that's true. But before we started to use exosomes and the stem cells for our patients. And here, this is the slide with added cycles of some of those patients are the same patients, some of those patients are new patients, just after we started to use the exosome and the stem cell therapy. So you can see here in the right side of the graph how the situation changed. I will return to one slide back for those who are patients over, I would say, 39, because after 39 we really can see the decline. And this is the situation after we started to use exosomes and the PRP. So it's still lower compared to those which are in there between 30s to 39. However, it's greater. Results are really excellent in terms, and this gives us hope, and that's why we started to share this, and we start to deliver this piece of information to our patients, just for them to make a right decision and to start using what's possible and what is effective and what will bring them together with us shorter into that end point or the middle point, which is really important. So just to talk about the clinical cases, that's a patient who was 38 in 2023. Her IMH was 1.2 nanograms per mil. She had 5 IVF cycles between December 2021 to April 2023. That was not with us. The maximum number of the oocytes she retrieved was 7. But never she had a viable embryo for the embryo transfer, patient for the mitochondrial donation. So while we started together, we had really many stimulation rounds. Patient is willing to accumulate her zygotes for the PNT treatment, but she wishes to have really many of them because she wants to have her relative as her mitochondrial donor. So we discussed the potential of that technology compared to the fact while we are using a known and proven donor and who is not a relative, because here the issue of having no viable embryos for embryo transfer is not clearly answered. If this is not like she's not a carrier of any gene related to the issue of maturation or fertilization, and we know the list of genes, so we are also using the technology, like we are understanding those issues as we are facing quite many and quite a lot of those. However, here, from the fact, the changes which we have seen in this case, we consider this as more the metabolic problem within her oocytes. So you can see the outcomes from from October, from December 2023, January 2024, and then another cycle which was duostim in January 2024, and during the egg collection of that egg collection, we also injected exosomes intra ovaries. And you can see that we had another round in the next month, and then 2 months later, we have another stimulation, which was we were able to retrieve 11 oocytes and creating 10 zygotes for this patient. That was really totally different outcome from whatever we had before, and that was the same protocol we were following. Like the same team was following her. That was the same type of the medications. Like nothing changed for her except this DUS team, which was different. But all the standard approaches, the protocols, they were the same. And next month, that was like 1 month and few weeks or 1 week, we had also 8 oocytes and 7 zygotes were created. And also morphologically from the lab, and that will be, we will have definitely one more series talking about the changes, but we need more data for this. The changes morphologically based on the AI selection of the oocyte, which we do for our patients, on what we see differently and what is the potential then for the fertilization and the further embryo development, because we believe that also we will see that potential as well. But in just recently, last month, we had another stimulation. And again, we retrieved just 4 oocytes and we were able to create 3 zygotes. So it looks like we returned back to the stage where we were while we started our stimulations almost a year ago. So this case really proves that we need to focus on the fact that we have a lifetime of the technology or the rejuvenation, which we need really to use effectively in order to help our patients. Like actually here we have the cohorts, and that was really nice cohort with her 11 oocytes retrieved. So another clinical case, and here there is a discussion on when we need to stop or which patient should we say no. And we had a discussion with our colleagues, with our coordinators, with our team who are receiving the initial requests for contact us form and so on. So we were thinking either we should create any cutoff for the age of the patient or for any specific, like age, of course, is the simplest question, like where should be the cutoff. However, this case proved that we should not decide about the cutoff just based on the single parameter. And if patient really wishes that we may try to help her, definitely we will. So this patient was 48 when she started her stimulation. She had kids before, so recently she haven't had stimulation, so she decided just to accumulate her zygotes in order to proceed with the pronuclear transfer because of understanding of her age and the potential that she will not be successful just using her regular IVF. So she had a stimulation in July 2023 where we retrieved 2 oocytes and were able to create just 2 zygotes. And in this treatment, we injected her PRP and the exosomes. What is important to say that we discussed with the patient also the cost of the treatment, and based on the cost of the treatment and then the potential of what we predict the outcome will be, we decide should we proceed or better not to. But always the final decision is the patient decision. So here there was a decision to proceed just with the PRP in every stimulation round. And you can see that total in 4 IVF for the patient, I'm sorry, here IMH, we just made a copy probably from the previous slide. So her IMH of this patient was 0.15. It's not 3, and it's 0.15 nanogram per mil. So this is a different patient, IMH. Really sorry for this. But she had this potential. And the good fact is that she really responded well. And you know that for some patients in her age or even sometimes over, that doesn't depend on the age, but most of the patients over 44, that even if we are having the reserve, we are growing the follicles, and out of those follicles, like here, we don't have number of follicles as well. So we accept if the follicular oocyte rate will be 80%. That's ideal. If we are lower than 50%, like we are having 3 follicles and then just 1 egg, that also can happen. But then we are talking to the patient, we are improving her like metabolic activities, we still recommend the list of the supplements. We are talking about diets and different technologies which may improve the outcome. So that's everything what patient can do, even though we are saying always this is not a magic pill, and the main responsibility of the outcome, this is ours. However, patients should help us always. So she also should be focused, and they really do. So within 4 IVF rounds, we were able to accumulate from 15 oocytes, 11 zygotes. And here I would like to share, because this is an excellent result, and really we do not have many cases like this. And always we are asked, like, what was your oldest patient for the pronuclear transfer or spindle transfer? So out of her 11 zygotes, we created 5 blastocysts, which is 46%. For some cases, we have even higher number of blastocysts, but here we had 46%. But the most important is that 3 out of these 5 blastocysts, they were euploid. We haven't transferred the embryos yet, because this very recent period when we just created those embryos, and we are preparing this patient, and that will be really responsible preparation. What we do in terms of the endometrium function and the implantation potential, but that's really amazing result for sure. So, and there is another case, which this patient was 45, and her IMH was 009. She had 3 previous stimulations with really very poor outcomes. We started in January 2024. That was one of our first patients when we had the stem cells injected. They were stem cells from the bank, from the stem bank. And we wanted to have immediately stimulation, but then she grew just 1 follicle, and that was not effective. We didn't had the egg collection then in February, and then we had the first egg collection in March, which we retrieved 2 oocytes. We were able to work with both. One was M2, one was M1, which we maturated and fertilized and created the zygote. Then the second stimulation was in April with 3 oocytes and 2 zygote created. And the third one was in May, 3 oocytes and 3 zygotes created also from M1. And 1 more cycle is planned for July. So patient aims to have close to 10. We hope to get 10 or more zygotes, and then we will proceed with the further treatment. So those results, they are still, we wish to work with the patient who will have just 1 stimulation round. We will retrieve a reasonable number of the follicles and eggs, and then we will create the embryos, but it's not always the case. And we need solution for those who were recommended, as I said, recommended the standard oocyte donation, and then just we need to quit and so on. But they were not ready to proceed with this treatment, because patients are looking for the innovations, they are looking for the technologies, and they need to understand what is possible and what we can do together for them. So that's why we are summing up the improved outcomes which we are getting with the ovarian rejuvenation using all 3 methods, the PRP, exosomes, and the stem cells. We are increasing the oocyte yield. We are improving the quality. It's early to talk about quality of the embryos. We need more data, but from the assessment of the oocytes, we are improving the quality of the oocytes. We are reducing the number of the IVF cycles and the overall time frame from the stimulation up to the period when we are able to proceed further, because retrieving the oocytes, this is just the very first point that's important outcome, but this is just the first outcome while we need to proceed further. We really admire and we wish to continue the research, and that's very important in this sphere. We are developing the interdisciplinary collaborations. That's why we are talking and we are discussing this treatment and all the opportunities and the technologies with the different spheres. Either these are stem cell banks or these are different technology in the sphere of the embryology and the development. And of course, we continue learning and educate ourselves and train our team and learn more from each other. So if you wish to join either the studies, or let's do the multi-center study, in order to, if you already have this technology implemented, if you have more patients, we can share the protocol, we can discuss the cases, we can learn from each other. I will believe that will be really beneficial. So something what we can do for you or for your patients. This is our really advanced and very effective mitochondrial donation treatment, which we were discussing, and I know probably you're following our results and data. So here we believe that this is really alternative to the oocyte donation, which works amazing and is a solution for the patients in their advanced maternal age who are receiving very low outcomes in terms of the blastulation, or they do not receive their euploid blastocysts, so that improves also the outcomes based on the euploidity rate. But for each patient, we should have, in order to be successful, we should have the personalized approach. We need to be innovative and open to the ideas and to its realization, and we are caring about our patient. The whole team of the IFG is a professional team which was support and the empathy of those people and all us. We will be really happy to guide you through the process and to help you to reach to the goal. So thank you for the attention. You can get more information about IFG on our website, or send us an email or scan the QR. You will get into our website as well and communicate with us in our social medias. We will be happy to either develop the collaboration with the professional, or if you are the patient, to help you directly. Just then, a little bit opening the next step, what we planned already for the beginning of August. That's another webinar where I promise to prepare more data and more clinical cases, and just to gather together the statistical data, which is still quite limited, but I believe I will be happy to share this in order our cases, what we have done in terms of the exosomes and the stem cells and the results we achieved so far. And I also invited the Dr. Ahmed Tevlik, who is the urologist, and he specializes on using the stem cells for severe cases of the male infertility, and that will be also like the overview of the data what we know already about using the stem cells for male infertility, and also the clinical cases which Dr. Ahmed already has. And then we will share more, and I believe we will be able to share also the specific date for the workshop in September, which we are planning to perform at Stem and Gene Art Clinic in Tirana, where we also cooperate with the Stem Bank, and we are having an access to both exosomes and the stem cells, both for the donor materials, or also the our team, like the Stem Bank team, which can help us to create, to use stem cells autologous from the patient. So that's really something what motivates me to be part of this really innovative approach, and I wish we will help more and more patients, and we will be able to share just fascinating clinical cases. And because after each of these cases is a real patient who is happy, and I'm really thankful to our patients who are sharing their result, because your support is really also important to every clinician. I believe this is true. So thank you so much, and if you have any questions, I'm happy to answer, if I may, because there could be something if that's specific for the processing of the cell or something, but you can always ask the question by email. We will share this as well. So let's move to that part. Thank you so much for your attention.
Thank you, Dr. Ulyana, for that fascinating presentation. I'm sure we all learned a lot, but let's get right into the questions. You are all still welcome to ask your questions or send your messages on the chat box, or as Dr. Ulyana said, just send us a message on any of our platforms. But here are some questions that I've received. First, are exosomes and stem cells the same thing?
No, exosomes are parts of the cell, which are extracellular vesicles, they are produced by the cell, but they are not a cell themselves. So they don't have a DNA, they don't bring a genetic information. They have an RNA, but which is different from the DNA itself. And as we said, they have a shorter lifetime and they cannot differentiate. They are helping the existing tissue where they will be working with, or which they will be helping to improve and to develop and to regenerate, but they will not become a tissue themselves. And this is different about the stem cells. So the stem cells, they are entire cell, which is, if we are talking about, let's say, pluripotent cell. So once we are injecting this cell, this is just a pluripotent. This cell can become any cell on the body. And let's say we injected the pluripotent cell into the ovary, so the cell can differentiate into the follicle in the ovarian tissue, and then the cell will act as the follicle, as the tissue it differentiated into. And then it will have the function of this cell, from which tissue it started. So that's different. Mechanism of action is different as well. So like it's similar in terms of the regenerating potential, but it's stronger for the stem cells for sure.
Okay, they do sound quite different. So, our second question is related. Can exosomes be used without stem cells for therapy?
Yes, that's what we presented, that they can actually also be used together. That's probably what we were not presenting because we haven't had those cases yet. But theoretically, we can inject also the stem cells with the combination of the exosomes. But because of the difference and then probably we will aim to regenerate the ovary immediately or almost immediately, focusing on the development phase of the follicles, of those which are ongoing, which are on the way to differentiate and to grow soon. And then we will have a long-lasting effect or longer-lasting effect from the stem cells further. So we had discussion with some patients already about this combination, but we never had the cases. But yes, they can be used also separately as just exosomes themselves, with the focus to rejuvenate and to feed the tissue, and then the stem cells differently, just with the focus of rejuvenation and creating the new cells.
Okay. I know you discussed earlier that they're different, but somebody asked in the chat box, exosomes were derived from which stem cells and how many numbers per ml? And conclusion.
So we were using the exosome derived from the mesenchymal stem cells, and they were 5 million in the ml.
Okay. I hope that answers that person's question. And I think our last question is, what are some challenges in using stem cells for treatment?
The biggest challenge which I had tried to address here is the fact that this technology is lasting for very few years, let's say, even not the decades, and we are still learning about the potential of the stem cells and about the potential risks as well. So the biggest challenge is the fact that we haven't learned enough in terms of the risks associated with the cancer and the risks associated with the immune response. Because for the fertility specifically, immune response is also very important, as we are having an implantation further, so we don't want to disturb, and we believe in the immunological infertility and in all the immune reactions in the body, which are so important for the systemic immune reaction and the response while we are making an implantation. So as the period of the implantation is possibly soon after we had that treatment, so also this immune response is not clear yet. That's why this is the challenge.
Okay, those are all our questions. Thank you, Dr. Ulyana, for answering all of them. But before we wrap things up, I'd just like to make the reminders that there will be a part 2 of this stem cell therapies webinar in August. This time we'll get to learn from Dr. Ahmed from Stem and Gene about stem cell therapy for male infertility, and he will explain everything from real cases and stem cell injection success rates to whom these treatments should be applied. And the second announcement, which Dr. Ulyana also shared, is that we will have the in-person workshop, the masterclass, in September, where different experts will show you practical procedures and results in the lab, and it will be held in one of our facilities in Albania, and we are inviting several stem cell experts, one of them being Dr. Ulyana, so you won't want to miss it. And we will share all the details on our IFG LinkedIn page, so stay tuned. This webinar is recorded as well, and you'll be able to watch this after on our YouTube channel once it's ready. Once again, thank you everyone for joining us, and we'll see you in part 2 of the Stem Cells in IVF series.
Thank you so much, and have a great evening, and take care, everyone. Bye-bye.
Bye.